Hello. Okay, so here we're going to continue our talk about chest pain, going into really angina. So in the first video we talked about how we were going to evaluate and decide if it was cardiac, and mainly that is if it's unilateral and radiating, and then basically checking for the risk factors. Of course, you guys know the CAD risk factors: obesity, sedentary lifestyle, smoking is a big one, diabetes, a diet high in fats, high cholesterol, non-compliance with medications. All of those things can be risk factors, and of course many more. So if we've decided that yes, we think that this is cardiac in nature, we've done an EKG. So let's talk about some things that we can use to treat someone having angina, which is chest pain. First, nitrates are vasodilators. They work on the venous system. They work to decrease the workload that is on the heart. They decrease the preload and the oxygen demand. Okay, so these are you can take it one every 5 minutes for a total of 3. And if your chest pain is still occurring, you need to educate your patients to go to the emergency room because they might be having an MI, and they're definitely having unstable angina. So what are the side effects? Okay, really we're looking at for these hypotension and a headache because there might not be getting as much blood. So the veins in the heart are opening up, and so the heart isn't, or the head is above it. It's not really like pushing anything or pulling any blood back down. It's not having good communication upwards. It can get blood below, but just not up. So you might have a headache because of that, and then also hypotension because you're opening up the blood vessels, so the blood pressure is going to decrease. One other side note of this, you cannot take Viagra and take this. So if somebody has chest pain but wants to take Viagra, you have to educate them that, you know, that is risky business. You have to really trust the patient to be able to say both of those medications can work, but you can't take them together. So if you've recently had a nitrate, you can't take Viagra. And sometimes that's a hard contraindication, especially with those patients who aren't going to be as compliant. So the next medication is a beta blocker, and you're going to use that for initial therapy for angina. The beta blockers are really great because they are cardioprotective. They're going to decrease the heart rate. They're not going to have so much of an effect on the blood pressure, but they will have an effect on the blood pressure. It prevents the remodeling of the heart, and for beta blockers, we really want one in everybody who's had an MI anyway. So this is going to be a medication you'll see common associated to angina. The side effects are pretty crappy. Your patient's going to feel like they're having the flu basically every day of their lives. They're just going to feel like generally fatigued and tired. And then the other thing that you're going to see is impotence, and it has to do with the blood vessels. So you're not filling the patient's penis as much with blood as they would have gotten before giving the beta blockers. And finally, it's just going to increase contractility. 2 types of beta blockers we want to look at. First, there's selective and there's non-selective. So the selective only affects the beta that works in your heart, and that's beta 1, and then beta 2 works in your lungs. So an example of a selective would be metoprolol, and there are 2 types of metoprolol tartrate and metoprolol sucrate. And tartrate is short-acting, sucrate is long-acting. Sucrate would be a great medication. It would make it so that your patient would have to take less pills and less times per day, but it is very expensive, so it's not a commonly prescribed medication. I'm really going to go with the tartrate. And then a non-selective would be like propranolol. And Lopressor is the brand name of metoprolol tartrate, and that's the one that you're seeing most often. So if you are going to give beta blocker to your patient with COPD, which, this is common. Our patients have all kinds of things. You better make sure that you give them the metoprolol. You cannot give them the propranolol, and even with the metoprolol, you can see some activity of bronchoconstriction. So that's going to be one of your other side effects for beta blocker, in addition to the generally flu-like symptoms and the incontinence. Okay, calcium channel blockers. So this decreases the oxygen demand by dilating the arteries. So we talked about the nitrates work on the veins, the calcium channel blockers work on the arteries. And that decreases the patient's afterload, which can also regulate the heartbeat. The side effect with this is fluid retention. The one that's really, really specific to calcium channel blocker is fluid retention. So if you start seeing your patient getting edema of the lower extremities, you want to think about taking them off of this patient. Taking this patient off of this medication. So there are two types of calcium channel blockers, and really, really very, very important for you to know. You have the DHP and the non-DHP. Now the DHP does not change the patient's heart rate. I just said that backwards. DHP, I said that right. DHP does not change the patient's heart rate, and non-DHP does change the patient's heart rate. An easy way for you to remember that, DHP means does not hurt pulse. No, it doesn't really mean it does not hurt pulse, but you can think of it like that. It has to do with the molecular structure of the calcium channel blocker. So a DHP drug, and so look at the patient's heart rate and decide which ones you want to put them on. The ones that are non-DHPs are the ones you're going to use for arrhythmias, more so than anything. Because that has to do with the way it interacts with the heart. Amlodipine and nifedipine are going to be the DHP. Doesn't hurt pulse, nifedipine and amlodipine. And then the non-DHP is going to be like verapamil. So that's why we see amlodipine a lot more frequently than we do verapamil. But when you see verapamil, just know. So aspirin. What's the mechanism of action of aspirin? You've learned this a long time ago, I'm sure. It blocks COX-1 and COX-2 irreversibly. And then the side effects is bleeding. So this is going to allow the heart, the blood, to travel easier throughout the body. And you're going to have a less likely chance of having a myocardial infarction. Now, if you have a patient who comes to your office and you think that they're having an MI, you're going to go straight to MONA, which is what? Morphine, oxygen, nitroglycerin, aspirin. Okay, and then the HGM co-reductase inhibitors. So these are your statins. So they're going to help to lower the cholesterol. They're going to lower the LDL, which is the low density cholesterol, which is bad for you. They're going to increase your HDL, which is your high density cholesterol, which is good for you. And they're going to decrease your triglycerides. Each statin has a different profile from the next one. The most commonly used one is Lipitor because it is a very potent drug and it is not expensive. It's actually moved to generic now, which makes it really good. Victoza is a great drug too. It's newer, it's more expensive, so you're probably not going to see it as much. So you don't want to use these in pregnancies or in patients with increased LFTs, liver function tests. So why pregnancy? Well, think about it. The baby needs cholesterol. If the baby doesn't have cholesterol, when they're in your uterus still, if it doesn't have cholesterol, it will die. So you can't take statins when you're pregnant. And then the LFTs, it's just because statins, the way that they are metabolized. And it used to be that you had to get LFTs, blood tests really frequently with statins, but not anymore. So what kind of side effects are we going to see from statins? Not really any crazy side effects, although the side effect that does happen when it happens, it bothers people, and that is muscle pain. So we want to get people to different goals. If you have coronary artery disease, which means you're hardening of the vessels, or a coronary artery equivalent, which would be diabetes, AAA, gosh, what are the other ones? Oh, chronic kidney disease. And I think there are like one or two other ones. If you have any of those, then you have a different goal for LDL than everybody else. Your goal is between 70 and 100, optimally 70. But still okay if 100, and it's very hard for patients to get to 70. If you do not have CAD or a CAD equivalent, then you can go to 140, and that's okay. Everyone's goal for HDL is 40, and Lipitor doesn't do too much to increase your HDL, so you want to educate the patient to eat more fish, which will increase the HDL. Next thing is the total cholesterol. I just want to let you know right now that's useless because it adds them all up. The HDL is good, so you're getting a falsely high number if the patient has a lot of HDL, and some patients do. So just useless. And then triglycerides, want to lower those, and Lipitor does not have as much of an action on triglycerides. So let's say you have a patient with a LDL of 200. What are you going to do for this patient? Now, 20 is not going to touch them. 40 is not going to touch them. You got to get this patient on 80 of Lipitor. And we used to say to take this before bedtime, and some patients still do that. It doesn't matter. It's okay. You can take it morning or evening, especially if you're already on morning meds, you can do that. So we need to get this patient on 80 if they have an LDL of 200, because that is very, very high. It would be okay if you started them on a lower dose initially, just kind of ease them in to the potential of muscle pain and kind of ease those side effects. Okay, so I hope that review of medications for angina was helpful. Thanks for watching.